Bismillahirrahmanirrahim. I am Dr. Azahr Chaudhry from FIC, and today I will be discussing briefly about the assessment of the left atrial function. This topic is critical for our advancing understanding of the cardiac function and improving the patient outcomes. So, left atrium is a far field structure located posteriorly, and it is smaller than right atrium. It receives oxygenated blood from the pulmonary veins, and it is a thin layer. It has a thin layer of muscle fibers as compared to the left ventricle. And the muscle fiber layers are arranged in two layers. So there is a superficial layer and there is a deep muscular layer. There are 5 walls of the left atrium: the superior, posterior, left lateral, septal, and the anterior. There is a left atrial appendage which has 4 types, and there is a variable thickness of the left atrium ranging from 3.5 to 6.5 millimeter. So left atrium plays a crucial role and functions in 3 phases, including reservoir, conduit, and contractile function. During the reservoir phase, it passively fills. During the conduit function, it fills the LV, and during the active contractile phase, it pumps the blood into the LV cavity. So it also functions as an endocrine organ and secretes atrial natriuretic peptides. So LA reservoir phase occurs during the LV systolic phase. During this phase, the mitral valve is closed and the LA gets filled from the pulmonary veins, and this reflects the compliance of the left ventricle. During the conduit phase, the passive filling of LA empties into the left ventricle, the mitral valve opens up, and 60 to 70% of the LV filling occurs during this phase. During the booster pump function, the LA contracts and active emptying of the LA occurs into the LV cavity. During this phase, LA fills 10 to 40% of the LV cavity depending upon the age of the person. This is the pressure volume loop relationship of the LA. So why do we need to assess the left atrial function? The left atrium is an integral part of cardiovascular health, both in disease and health, with 4 important clinical implications. It is an important risk stratification tool for conditions like atrial fibrillation, stroke, and heart failure. It is an important diagnostic marker for left ventricular diastolic function. It has an important prognostic value for both CV morbidity and mortality. And it also acts as an imaging biomarker. What are the different methods to assess the left atrial function? Left atrial function can be assessed on different imaging modalities, including transthoracic echocardiogram, cardiac CT, and cardiac MRI. Cardiac CT and cardiac MRI are complementary to the echocardiography, which is the most commonly used and easily available modality. Traditional echocardiographic methods like measuring atrial diameter, area are simple and cost effective, but they have limitations such as geometric assumptions and limited prognostic value. Newer methods address these gaps and offer more accurate assessments of left atrial functions. Since left atrium is placed in the chest in a way that it does not enlarge in AP dimensions at the earlier stage, so most of the time the linear dimensions, they underestimate the size of the left atrium. And because of these geometric assumptions and inability to assess left atrial function, these methods are now not recommended in the guidelines to measure the left atrial size. Newer methods which address these gaps offer more accurate assessment of left atrial function include volumetric analysis, spectral Doppler, tissue Doppler imaging, and deformation analysis. Each of these methods has their own strengths and limitations. Tissue Doppler and deformation indices of the LA functions include strain S prime, which shows the reservoir function, conduit function is represented by the E prime, and the booster pump function by the A prime. While spectral Doppler indices, they can measure the conduit and the booster pump function, and the volumetric indices like global function, reservoir function, and the conduit function. But all these methods, they have their own strengths and limitations, and because of the limitations, they are not commonly used in the clinical practice. Like tissue Doppler imaging has an angle dependency and motion and tethering issues. While simple Doppler acquisitions, although simple, are easy to interpret, but they are non-specific. And the volumetric analysis is cumbersome and time intensive. So coming over to the left atrial volume index, which is the most commonly used parameter and strongly recommended in the guidelines for assessment of the LA size, which is an indirect measure of LA function. Though it is difficult to quantify the LA size, but it is strongly associated and an accurate risk stratification marker. LA dimensions are measured in the apical 4-chamber and 2-chamber views, and from the cardiac MRI studies, we know that the long axis of the left atrium is not aligned with the long axis of the left ventricle. So to acquire these images, in order to have a true left ventricular atrial assessment, we need to have an optimized left atrial view. There are many studies that have validated the superiority of the left atrial volume index over the left atrial diameter and the area. So how do we measure the left atrial volume? 4-chamber and the 2-chamber views are required, and the length, the difference between the length of the two acquired views should not be more than 5 mm, or the area should not be differed by more than 10%. Normal range of the LA volume is wide across the age groups. In 90% of the people, the normal left atrial volume index is less than 34 ml per meter square. This is the value which is recommended to assess the left ventricular diastolic dysfunction in all the guidelines. However, there is a variation in the even entirely normal hearts. Like 10% of the people may have a left atrial volume index more than 34 ml per meter square. About 5% may have the left atrial volume index more than 37 ml per meter square. And there are studies which show that up to 43 to 45 ml per meter square of the index LA volume may be present in the normal population. LA volume is not a reliable indicator of left atrial pressure. There are certain limitations to the left atrial volume index, though it is a very robust risk stratification tool. Like in atrial arrhythmias, valvular heart disease, young athletes, or bradycardia, the LA is enlarged, though the LA pressure may be normal or the LA function may also be normal. Coming over to the deformation analysis or the strain imaging, which is the most sensitive marker for assessment of the left atrial function. Myocardial deformation can be assessed by tissue Doppler imaging or 2D speckle tracking echocardiography. 2D speckle analyzes the motion of by frame by tracking the natural acoustic markers without angle dependency. However, it requires good quality image and a certain frame rate. It has a greater sensitivity as compared to the volumetric analysis and the Doppler parameters. So how do we do it? So left atrial strain is measured by ECG gated study. There are two methods to gate the study. Either we can use the R to R gating or P to P gating. Most of the studies are done based on R to R gating. So all guidelines recommend to use R to R gating. The proportional values of the reservoir and the conduit strain do not change much when we use either R to R gating or P to P gating. A single apical 4-chamber view or biplane 4-chamber and 2-chamber or apical 3-chamber as well can be used. But the recent guidelines, they recommend a single apical 4-chamber view is enough to measure the 2D LA strain. But we need to have an optimized view, left atrial view, to have a good recording. So the first upstroke is a positive value, which is a reservoir strain in R to R gating, and the first downstroke is the conduit phase, and the third downward stroke, which is a negative value, is a booster pump function. So these are the normal values of left atrial strain in both genders. There is not much of a difference between the two genders. The advantages of the left atrial strain: it is a comprehensive functional assessment. It has a good prognostic value. It is non-invasive and it addresses all the phases of the left atrial function. But the limitations are that it requires a good quality image. There is a vendor variability, and it is time intensive, and there is limited availability across the country. So it is a good and proven prognostic, diagnostic, and a therapeutic marker in different diseases like chronic mitral regurg, rheumatic heart disease, cardiac amyloidosis, coronary artery disease, obesity, and diabetes. The most commonly assessed abnormality of diastolic dysfunction, the left atrial function is most commonly impaired or decreased in left ventricular diastolic dysfunction. So in left ventricular diastolic dysfunction, the earliest parameter that goes down is the strain. Even before the left atrial volume, E to E prime, or exercise E to E prime. So this is the most sensitive marker that picks up the left ventricular diastolic dysfunction at the earliest stage, while rest of the functions, they take some time to predict or give the indication for the left ventricular diastolic dysfunction. And the left atrial reservoir strain also has a linear relationship with all the grades of diastolic dysfunction, with gradually decreasing as the severity of the diastolic dysfunction increases. So this is a document from the recent guidelines, the British Society of Echo guidelines published last year, and these guidelines adopted the left atrial strain in cases where the left ventricular diastolic dysfunction is indeterminate. So in all these three algorithms, patients with low EF, less than 50%, normal EF, or atrial fibrillation. In cases where there is no clear-cut diagnostic criteria for the left ventricular diastolic dysfunction, so they have included the left atrial strain. In the patients with less than 50% EF, the cutoff value is for reservoir strain are less than 18%, and for the pump strain less than 8%. While in atrial fibrillation, the cutoff value is less than 16%. So 4D LA assessment is the new tool which is available in some new machines, and this is one method that can quantify the volumetric analysis and the volumetric strain analysis. So this is going to be the new tool which is going to be available soon, and it can measure the strain in both longitudinal and circumferential. So the 2D speckle train has a limitation that it can only measure the longitudinal strain, but the 4D left atrial quantification volumetric strain analysis can measure both the longitudinal as well as the circumferential strain. See, the images are acquired with 4D probe in a single beat or a multi-beat, where 4 to 6 beats are required. This is also an ECG gated study. And these are the horizontal lines and the circumferential lines which analyze and measure the longitudinal and the circumferential strain. These are the waveforms of the longitudinal and the circumferential strain. So then the views are aligned, and this is the data sheet that comes out after the results are given by the machine. So it measures left atrial emptying volume, it can give us left atrial emptying fraction, it can give us left atrial expansion index, left atrial pressure, passive emptying and active emptying. So 4D is a new technology and it has a steep learning curve, but the studies have shown that there is very less inter-observer and intra-observer variability if you have learned the technique. And there is a growing literature in favor of left atrial function assessment using the 4D volumetric and volumetric strain analysis. So 2D has its own strengths, including the wide availability, validation in multiple studies, reproducibility, but it also has operator dependence and requires a good image quality. 4D is more accurate. There are no geometric assumptions in the 4D LAQ. It is more comprehensive, but the cost, limited availability, and steep learning curve are the limitations of this new imaging modality. The assessment of left atrial function is indispensable for understanding the cardiac health. It is invaluable. 2D and 4D are the invaluable tools to assess LF function. 2D is widely available and recommended by the guidelines and can assess all the phases of the LF function. 4D offers enhanced accuracy but with steep learning curve and cost constraints. Earlier and accurate LF functional abnormalities can detect and help risk stratify, make therapeutic decisions, and improve patient prognosis. Thank you.
Thank you very much for a very lucid presentation. And it is so important now that instead of measuring the left atrium, we should be measuring the left atrial volume index in all patients that we see, number one. Number two, when we are doing a left atrial strain, can we detect those patients who will ultimately go into atrial fibrillation, who have the risk factors?
Absolutely, sir. So left atrial strain studies have shown that left atrial strain starts going down as early as a decade or 2 decades before developing the volumetric or anatomical abnormalities. So this can predict the development of atrial fibrillation, can predict the recurrence of atrial fibrillation after cardioversion or ablation, and can predict the response to cardioversion or ablation. So strain is a strong risk marker for atrial fibrillation, and it has been mostly studied in population with who are at risk of stroke or who are at risk of atrial fibrillation.
If, for example, you don't have the software for left atrial strain measurement, can you use the left ventricular strain measurement to be able to measure it? But you can use the right ventricle.
Yes, we can use that. That has been used. Definitely. Till now, I mentioned this combination. They have got three parameters, the software for three chapters, not for RE. They use LA parameter. That has been used initially. LV software was used for RD, for LV, not for RE. But now,
I think that is right. You need a dedicated software, especially for the left atrial strain and for the right atrial strain, because I tried to use it, but the curves go out of place, and therefore I think you need a dedicated software for it.
It's just a change in the length. Now you can do better if you do just LV volume and length measurements. That software also gives you straight values. You check on your machines, because it's just the change in the length that it is giving. It cannot give you regional, but it can give you that this was the length of the LV in diastole. Now this is the length in systole. That's what we need for strain, right? But this is a crude method, I should say. Secondly, this LAVI measurement that has progressed in our time. Previously, 28 was taken as the normal value, and 34 was taken as a moderately enlarged LA. But now they have changed it. This is evolution. This is science. This is how we adapt to new things. Thirdly, my question is, do you measure EF, LA EF? And what is the value of pre-A-LA volume? Because that
Imran, can we have questions from
sure.
Dr. Tipu and Dr. Abid?
My question is, in the absence of left ventricular disease, whether it is systolic or diastolic, does the inherent LA disease predict the future AF, or what type of a disease we can expect inherent from the LA in the absence of LV involvement?
Yes, sir. Left
I mean,
atrium.
mostly the left atrium is affected by mitral valve or by left ventricular dysfunction, either systolic or diastolic. Can we assess LA function in the absence of LV disease so that can predict in future that a patient can go in atrial fibrillation, like we come across with lone atrial fibrillation in the absence of any disease
Yes, yes.
on the in the left ventricle?
Absolutely, sir. Left atrial strain has been studied in normal subjects or people with risk factors for atrial fibrillation without overt myocardial disease. And it has been shown to predict the development of first episode of atrial fibrillation. And it is such a strong predictor that it can predict, it starts to get impaired a decade or in one of the studies 2 decades earlier before the development of the atrial fibrillation. So yes, it can definitely predict.
And measuring the LA size, we commonly do this transthoracic long axis view and compare it with the aorta, and then see the size, whether what is the normal size and more than that. So is only the 2D long axis view enough for seeing the size, or we have to go for a 4-chamber and see the long axis also?
Yes, yes, sir. That is why the left atrial volume index has superseded all the previous measurements, sir. So left atrial volume index on 2D is inferior to 3D, and 3D is inferior to CMR. CMR is the gold standard, and 3D biplane is closest to the CMR. 2D and 3D, there is between 2D volumetric assessment and 3D volumetric assessment, there is a difference of 5 to 8 ml per meter square. So the area and the 2D and the M mode measurements, they are they are not recommended in the guidelines for assessment of the left atrial size.